Hello, this is Dr. Michael Clinton, and I'd like to welcome you to my office, and let's talk. Let's talk about breast augmentation. You're in good company. There are lots of ladies that have contemplating enhancing their breasts. It's a very common operation that's done. We do it commonly. Plastic surgeons are trained to do a lot of different things from head to toe. But if you were to ask me what the focus of our practice is, it would have to be breast enhancement, which includes breast augmentation with lifting, breast reconstruction, and breast reduction. So it's a pretty comprehensive list of things that we do for breast enhancement. Breast augmentation, even though we do a lot of it, this is not a cookie cutter approach. It's not a one-size-fits-all practice. There are practices who do 8 to 10 operations a day. That's not our goal. Our goal is to do the next one we do the very best that we can. Our goal is to take all of our experience, all of our training, and your input, of course, and give you the very best possible result that we can give you, and something that's going to last you hopefully the rest of your life. It's an operation that takes about an hour to an hour and a half to do. It's done here in our office operating facility. It's a fully accredited facility. That's not a doctor's procedure room, if you will. It's a fully accredited operating facility. The local hospitals here are no more accredited than this operating facility. Board certified, core trained plastic surgeons have to work in a fully accredited facility. We set that standard for ourselves years ago. We take every opportunity we can to let you know that that's what we provide for you. A nurse anesthetist will do your anesthesia. They're extremely good at what they do, and they are in attendance at all times for your operation. You have lots of options. And those practices who do that are based on volume don't necessarily discuss those options with you. We think that you deserve at least a discussion of the options, and that's what you'll get from me during a consultation. One of the options, of course, is breast implants. There is so much information that's available about breast implants that we could talk about breast implants for weeks and not scratch the surface of that information. That's good, but at the same time, it's rather frustrating for people. So allow me to be your guide through that, and I think there's a certain baseline of information that you need to know that I'm going to tell you regardless about breast implants. We've had breast implants since the 1960s. We've had both saline filled and silicone gel filled. Both implants have a silicone shell, so you get silicone with either implant. And from the very beginning, silicone gel filled implants were much more popular because they felt more natural. But it wasn't until 1992 that the FDA stepped in and said, we don't know if there's enough information about breast implants to tell us that they're safe or not. And we said, well, tell us what you know. And they said, well, we don't have any information that says that they're not safe. We just don't know if there's enough information to say they are safe. So you can see where this argument was going. We said, look at our 30 years of research that we've done from the 1960s to the 1990s. They said, well, you guys might not be totally objective since you do this for a living. We weren't making any more money off of gel implants, so I'm not sure where that came from. But nevertheless, what happened in 1992 is that the FDA restricted the use of gel implants. Notice that I didn't say the word banned, because they didn't. They did not ban gel implants. In order to ban them, they would have had to have known something was wrong with them. So they specifically restricted them for the purpose of bringing the total number of gels that were being used down until they could be studied. So that's what happened from 1992 until November of 2006. For 14 years, we had only saline implants for breast augmentation. But if you wanted a breast augmentation with a breast lift at the same time, you could use either implant. So I would have ladies in my office that would say, well, if it's okay for her, why isn't it okay for me? Well, that was the whole point. They couldn't tell you that it wasn't okay for anybody. So they achieved their goal. Their goal was to bring down the total number of gels that were being used. But it is important to know that they never banned gel implants. So in November of 2006, they released them for unlimited use with all the information that they had learned. They couldn't tell you that there was really anything wrong with a gel implant. So what happened in 2006? The numbers of gel implants zoomed back to the forefront, and there were several good reasons for that. One is that during the era where saline implants were used predominantly for breast augmentation, that patients noticed that there was a phenomenon called rippling. Every patient rippled. Every saline implant ripples. It's just a matter of whether you can see it or not. Rippling does not hurt anyone. Rippling is just simply a cosmetic thing. So a lady takes off her bra and leans forward, and she sees this waviness, and for people that are trying to do things to enhance the appearance of their breast, that's not what they're after. So a lot of those patients changed from saline implants to gel implants for that reason, to decrease the chance of rippling. And gel implants don't reduce that to zero, but they significantly reduce the chance of seeing rippling. But at the same time, not only did they notice that, but they noticed that these implants were lighter, which to me is a very significant thing if we're thinking about how durable your appearance is, that perky, lifted appearance is going to be. Then you want the lightest possible option for your implant. And then thirdly, they noticed that they felt more natural. Now, saline implant patients have never really complained much about natural feeling once they got past the first couple of weeks and realized that that's just the way a saline implant felt. But when they compared it to what a gel implant felt later, they said there was just really no comparison, that the gel implant was superior in that sense. So what happens? Gel implants zoom back into popularity, and I rarely put a saline implant in. Another option you have is whether you put the implant above or below the muscle. Back during the era where we were putting saline implants in predominantly, you really needed to put those mostly under the muscle, because it made that transition for the upper chest to the shape of the breast a more smooth transition, a more natural transition, and not an abrupt transition like the Pamela Anderson look. I don't know what era you're from, but some people know who Pamela Anderson was from the Baywatch days, and it was just a little tiny body with just a very abrupt, large breast shape, and most patients are not after that. I lost my train of thought. When we say under the muscle, we should more accurately say partially under the muscle, because it's not total muscle coverage. The pec major muscle comes from your shoulder across the chest. It inserts along the clavicle and down the sternum. And what we do is we release it here medially and place the implant partially under the muscle to give you that smooth transition. Well, the lower outer part of that implant is not covered by muscle, so that's why we should say partially under the muscle. With the new gel implant, it's not necessary to do it under the muscle unless the patient has such low breast volume and so low body weight and low fat composition. What I mean by that is soft tissue coverage. In those cases, still putting it partially under the muscle would be a good thing. Now, the modern gel implant is not like the one that we had in the 60s. That was a liquid gel. Now we have what's called a highly cohesive gel implant. What's the difference? One is essentially a liquid. The other one is a gel that if you were to cut a pie-shaped portion out of the implant, it would stay that way and it would not fill in like a liquid would fill in. I think that's been a major advancement in the production of gel. They describe the gel implants by generation, and we're into depending on who you follow and believe, the 4th or 5th generation of gel implants. But being highly cohesive, more like a true gel, has been a significant advancement. There are words like form stable and gummy bear that describe some of the newer implants, and we'll talk about that at some other time. But the other option you have is the shape of the implant. They have round implants. Some people say they aren't shaped, but round is a shape. And then there are truly what they call shaped implants, meaning that they're not round, they are taller than they are wide. They have more volume in the lower pole than they do in the upper pole. Kind of sounds like a normal breast. There's nothing really new about shaped implants, although they have gained recent popularity. They've been around for 20 years or so. Early on, I think they were too tall and too narrow, and they were not giving enough cleavage. The adjustment in the shapes of shaped implants have made them more popular, and they have application. I don't think it's just use all shaped or just use all round. I think we should match the implant to the patient's anatomy and her needs. And we'll discuss that after we do your examination. Another option is how you put the implant in. There are 4 basic ways to do it. I would tell you right up front that 95% plus of the time it's done one particular way, and that is through the inframammary fold, and that is through a small incision just above or in the fold under the breast. It gives you direct access to where you need to put the implant. You can't see it in your bathing suit. You can't see it in your bra. And frankly, with nothing on, you'd have to lean back, lift your breasts up. Someone would have to get very close to be able to tell if there's a fine line scar there. The other options would be through an incision in your armpit. Was very popular for a while. It can leave you with some numbness on the side of the breast. If you ever have to do any kind of a revision, it'd be very difficult to do it through that same incision. If you're laying on the beach with your hands behind your head and you have a little scar out in your axilla, someone could possibly see that. And granted, most people aren't looking at your armpits at that time. Another option is around the edge of the areola. It's called a periareolar scar. It was very popular for a while. With the development of a theory called biofilm, and I say theory, some people think they take it as fact. Some people still question the significance of biofilm. Let me explain biofilm. Biofilm, it has to do with the bacteria that are in the ducts of the glandular tissue, and if that is released and can get into the pocket that you have developed for your implant, there could be a colonization, if you will, not necessarily a frank infection, but just a colonization that could lead to the development of capsular tightness. Some people call it capsular contracture. That implies some kind of a muscle. I'm not sure that I like that term, but CapCon for capsular contracture is a shortened way to describe that. So some people believe biofilm has something to do with CapCon, and that going through the edge of the areola, through the periareolar approach, through the glandular tissue to create the pocket may lead to higher rates of CapCon. The other option that you can see on YouTube, if you're watching this, then you're familiar with YouTube, is the tuba, transumbilical breast augmentation. I've never done that procedure myself. I think it violates every principle of being meticulous with this operation, but it's taking a saline implant and placing it through an incision that's made in the umbilicus, that's then tunneled up to the area underneath your breast. And it is an option, and some people actually do those frequently.